really interesting presentations for each day, a really diverse set of presentation. It's also really nice to see that the people presenting are from a diverse group, really multidisciplinary team that's represented. The first of which we have is Diana Garcia. She's the DecodeME Project Manager from the University of Edinburgh. And online, hopefully. We also have Sian Leary, who's a member of the DecodeME Patient and Public Involvement Steering Group. I'll hand over now.
Thank you all. I apologize for the difficult start. Thank you for the help from the technical team. We are kind of in a DOI situation where Sian can hear us via my phone, and we hopefully can hear Sian doing her presentation. Okay, so I'll start. My name is Diana, and I'm the project manager, as I was introduced. Thank you. And I'm here today to talk about the DecodeME project and how patient and public involvement has impacted positively different aspects of the project. And in this particular case, we will be focused on recruitment. Sian is presenting with us, with me. This is co-production DecodeME with researchers and members of patient and public involvement group, and we wanted to share this co-production model also as a presentation, even with a little bit of difficulties this time. Okay, ME is a complex disease, it's a chronic disease. There are multiple symptoms. Some of them are unrefreshing sleep. We have also orthostatic intolerance. We have cognitive dysfunction, but the cardinal symptom is post-exertional malaise. There is estimated that over 250,000 people in UK suffer with this disease. 1 in 4 are estimated to be bedbound or housebound, and unfortunately there are no diagnostic tests or treatments available. So DecodeME, as I said, is a partnership between people with ME and researchers, is the world's largest ME-CFS study. And the aim is to collect up to 25,000 DNA samples to study the differences in DNA between people with the disease and people that don't have the disease. But it's much more than a genetic study. It will also be open source for phenotype and genotype data. That will be an amazing step for future research in this area. Participation is simple. People can contact us by phone, email, or post, or can go directly to the website. They have to fill out the questionnaire, and which can be done online or by post. And we also have phone support for anyone that needs it, or they don't have access to, or it's difficult for them to participate via post or online. And Helen Baxter from the 25% group is helping us out with this. Then the ones that are invited to donate their DNA sample, they will receive the kit in their letterbox, and they can post in any post box close to them. So it's really accessible. The next step, I'll pass the word to my colleague Sian, is to talk about how PPI has improved our research and improved recruitment.
Thank you very much to Diana for starting us off. So my name is Sian Leary. I live with myalgic encephalomyelitis, or ME, and I'm part of the Patient and Public Involvement Steering Group for DecodeME. So to jump right in, our team recognised from the off that recruiting 25,000 people with ME was a huge undertaking. This equates to roughly 1 in 10 people with ME in the UK, and we know that many people do not get a timely or accurate diagnosis. So the pool we're trying to reach is actually much smaller than 250,000 people estimated to have ME in the UK. To efficiently recruit this many people, we knew we needed to make this study as accessible and relevant as possible and bring the ME community along with us as we undertook this important research. To achieve this, we have embodied the principle that runs throughout the disability movement: nothing about us without us. Slide. So we wanted to share a little bit about the structure of DecodeME and how we have centered people with lived experience throughout. Here you can see our PPI members filled in green. Our PPI steering group has oversight and signs off most decisions, and particularly the forward-facing documents and processes that our participants have to go through. But we also input and advise on standard operating procedures, our risk register, and loads more. We have a management group that has delegated authority from our chief investigator, Chris Ponting, to approve all decisions made within DecodeME. This team is made up of 2 PPI members and Chris himself, meaning that we have a majority PPI membership of our management group. We've then got 3 teams working on different areas of the project, all of which include people with ME and or carers in positions of equal standing with researchers. I'm personally part of the cohort delivery team, tasked with getting all our participants through the necessary processes, but I've worked closely with the marketing and comms team, and I've got oversight of the genetics team's work through our PPI steering group. All of our other subgroups still have that oversight by PPI members. Slide. So our patient and public involvement members have really differing capacities to attend meetings, develop documents, edit and comment upon processes and everything else that we do. And considering that ME is a fluctuating illness, what our PPI members can do one day isn't necessarily the same the next, myself included. We work predominantly online and arrange meetings and work in a way that allows each member to be as involved as possible. We have always actively supported members to attend our online meetings from whatever position works for them. And I know I'm not alone in having attended meetings from my bed on my worst days. This is also a good point to mention that co-production like this takes time and investment from all involved. We have had to slow down at various points to give our PPI members time to properly engage in our work. This has led to more considered work of greater value and had unforeseen benefits, but the time and investment needed shouldn't be underestimated. Slide. So in practice, we wanted to give a few examples of how PPI has had a big impact. A major part of our participant process in DecodeME is our questionnaire. This assesses a huge variety of symptoms that people experience, their impact on the participant, and things that are important for our data quality control, like sex assigned at birth and blood group. We then use an algorithm to select our DNA participants. Creating an accessible questionnaire with relevant questions that acknowledge the nuanced and varying experiences of people with ME and allow them to provide authentic responses was hugely important to getting the number of participants we need. We know from personal experience that when research doesn't do this, we give up partway through participating. Our PPI teams co-developed the questionnaire, then sent it out to an initial set of participants to fill in, along with a survey asking them for feedback. While much of the feedback was positive, some issues were raised, and a sufficient number of questions being filled in incorrectly raised concerns with us. Based on this, our PPI teams once again went through the questionnaire, tweaking language and improving the overall flow. Once implemented, we saw a 20% reduction in the number of paper questionnaires being filled in incorrectly. This saved a huge amount of staff time phoning participants and asking them for answers to questions they hadn't filled in or had done so incorrectly. Slide. Another area that PPI continues to make a difference in is our participant support. Staff at DecodeME are on hand to answer questions and advise participants on the processes they go through. Some of these questions come through repeatedly, so we have co-developed standard responses that are sensitive to the circumstances of people with ME. But beyond this, we have a channel dedicated to participant support on Microsoft Teams. If there's ever a question that doesn't have a simple answer or a standard response, our PPI team is on hand to support staff in responding, using our knowledge of the stigma and challenges people with ME face to ensure that the support they are given through DecodeME doesn't hit old pitfalls. Slide. So beyond this, PPI is involved in creating so much of DecodeME. While much of our more visible involvement is in the processes participants go through, we are also supporting behind the scenes work. For example, the cohort delivery team had to make recommendations to the management team on which suppliers to go with for spit kits and print and distribution services, and oversaw the development of delivery plans and standard operating procedures. This impacted important decisions around how often we were able to send out batches of spit kits to participants and the comms work needed around this. Our PPI members have also done a huge amount to support social media work, created videos and content themselves, and participated in our webinars, which often get thousands of views. Without this, I don't see how DecodeME could have reached anywhere near the numbers we have in just over a year since we opened recruitment. So let's look at those numbers. We've had 36,000 people sign up to DecodeME. Of those, almost 26,000 have been through the consent process and questionnaire. For those who do complete the consent process, we're seeing over 99% provide their consent, which I feel is a testament to the trust we have built in this study and that we give people clear and simple choices over how we use their data. At present, we have invited just over 20,000 people to provide their DNA, and of those, 16,000 have now returned their spit kit, but we expect this to keep on rising. Considering we are just beyond a year since we opened recruitment, these numbers feel like a huge achievement. Yes, we have a way to go to reach our goal of 25,000 DNA samples, and yes, in all honesty, we may not reach that figure, but we have created the largest resource of phenotypic and genotypic data on people with ME in the world, and we can't wait to see what the genetic analyses that we are currently undertaking tell us about this disease. Next slide, please. So what have we learned, and what do we want you to take away from this today? It is possible, and more than that, it can be advantageous to give people with lived experience majority decision-making power within a research study, and further down through the teams and structures of a project to work with people with lived experience as equals, part of which means paying them a fee for their time in line with national guidance too. Patient and public involvement members have different incentives than researchers to be involved in work like this. We are driven by our experience of a disease that has a profound and debilitating impact on our lives. For us, the urgency of research like this cannot be understated. We want our functioning back and not to live with a daily onslaught of symptoms. Yet it is just this experience and urgency that means we can make research more relevant and accessible, and allows us to improve the scientific value and therefore monetary value of studies like this. I get that for anyone, devolving decision-making can feel like a scary act, or involving PPI consistently in all your team's work may feel unfamiliar, but doing so can create something truly powerful. You won't be able to see to foresee the exact benefits to your work until you do so, but believe me when I say they are there if you invest the time to support PPI. Next slide, please. So before I pass back to Diana to take questions, we'd both just like to say a huge thank you to the thousands who have participated in DecodeME, to our PPI team and incredible staff team, the other organisations supporting and funding this work, to those organising this conference who enabled me to be here today in an accessible way, and to all of you listening. So thank you very much, and I'll hand back to Diana to answer any questions.
Does anyone have any questions they would like to ask? Carol?
So I think you said, or Sian said, I think at one point, that involving people sometimes slowed down the process, perhaps when there was disagreement or you weren't sure how to move forward. But we heard this morning from some of our speakers that we need to be speeding up how we're doing our research. How do you think PPI and speeding up research can work together, and how I guess, what does that culture change look like with PPI partners pushing back and slowing down? Perhaps I can give my perspective as a project manager, and Sian can give her perspective as a PPI member. So I think it's all about communication and preparing things ahead. We need to understand what our PPI needs, but everyone in the project needs, and allow that to happen. We had to slow down at times because PPI members could not input as they wished because of their symptoms and the energy levels. But allowing them to understand what is required of them ahead of time in a simple message, they will be able to participate and move forward faster without misunderstandings, without confusion. I think it's just about communication and understanding people. Now I'll pass to Sian. Sian? I think she... No? Okay. Well, I hope she agrees with me. No, that's it.
Thank you. Any other questions from you?
Thanks very much for your presentation.
Yeah.
I'm interested, you mentioned national standards. I just want to elaborate on that. Is there any NIHR standards that you're using?
UK national standards.
Right.
Yes.
What body are they from?
Well, I think they are associated with NIHR.
NIHR.
Yeah. But they are called the UK national standards.
And then in terms of the funding model that you have, I'm very clear as well that PPI must be adequately funded and remunerated. And in the work that we're doing, and I'm going to talk about that later on, we're finding some pushback from colleagues where there's a culture of PPI has been done for X amount of years in this way and for free. How have you come across that in your work, and how have you got around that?
Well, luckily enough, we haven't come across that that type of narrative, but I think there is a difficulty to actually plan better PPI inputs in a meaningful way, and also pay what they deserve to be paid, which is the minimum wage. And it needs to start being implemented. I think funders are aware of that, but more and more people need support to include that perspective from earlier on their grants. I think there is it's very difficult to understand how much PPI time you need in your project. And at the grant stage, you often will see that your budget was very different from what you have in year 0, is very different from what you actually have in year 2. This happened to us as well, and we had to adapt. And PPI was very flexible on all of that. So I think there is if you can attend workshops that help planning PPI and engage with any funding, I'm sure NIHR, MRC, for example, will be open to discuss this with you as well. It's all about starting at this stage.
Thank you. I think we've got time just for one more question. Julie, did you have a question?
So my name's Jane Hayden, I'm in Scotland. And so we work a lot with people who want to and we engage with people through the out of processes and so I just wanted to say about payment. So we also want to pay time, but people without illnesses are not able to work in time.
Yes.
See benefits from government. If we pay them, they will reach their benefits often for many, many months at a time. For very, very small amounts of money. So yes, we need to pay them time, but please, very, very, very negative impact.
Absolutely. I could not be more supportive of your point. I think the best to do is to, and this is very early stages, is to engage with PPI, create discussions even before the grant application, and understand what are the needs of the people that you engage with. And this is a very good point. It needs to be, it needs a progression here. There is no other way, because without payment, if we are paid full time and they are PPI members in our group, they are contributing a lot, they are very active. Why they cannot be paid for the same amount of money if we are spending the same hour in a meeting? So I think it's important that we acknowledge everyone's contribution.
Very quick. Well, it's not actually a question. I just wanted to highlight that the national standards on the PPI were developed by sort of cross-nation group. So I was a representative for CSO, there was representatives from Wales, there was representatives from Northern Ireland. So they are truly national standards. They are not NIHR standards.
Okay, sorry.
Thank you so much for that. Thank you for your presentation. I'd like to invite Sarah Robertson up next. Sarah's the Youth Engagement Lead for Generation Scotland from the University of Edinburgh.
Firstly, thank you so much for inviting us along today. I think most of Generation Scotland are actually in the room just now as well, so please feel free to ask them questions later on too. So I'm Sarah Robertson, and I have recently started working with Generation Scotland, but my background is with youth engagement and also sort of 25 years doing community work, community engagement, and I used to work with Youth Link Scotland, which is a national agency for youth work. So really coming at it from a different perspective and still very much learning from the academics that are around us, and also the health research experts too. I would like to slow down a bit actually. I talk really, really fast, so apologies if I'm kind of sort of, please just slow me down if needed. So I would say it's a very much a team effort as well. So we couldn't do this alone. So there's a really fantastic team at Generation Scotland that are helping to drive the work forward, and are also involved in supporting young people through various youth advisory groups and also through kind of sort of the organisation as a whole as well. So you maybe heard, well, you hopefully heard Heather earlier on today as well. Heather's really kind of, she's one of our chief scientists as well, so it's a really kind of instrumental, and also Robin, who's in the room as well. So questions to Robin at the end. Forward. Okay, so you might wonder what on earth this is about. I try to, when I'm doing any presentations, put myself back in if I'm doing like sort of work with young people as well and incorporate some of that into the room. So I talk an awful lot, and I think a lot of people here are kind of nodding. So when I get to about 10 minutes, could I ask somebody with a watch if you could just start kind of squeezing the chicken? That would be great. And if anybody else, Niall, you can get one. If I go beyond the 10 minutes, feel free to lob a beanbag at me. Please don't knock me out, although we are near the hospital, so it should be absolutely fine if we don't survive. I hope I do survive. But because Generation Scotland has been going for a long time. So since 2006 it started. As Heather mentioned earlier, we are the largest family health study in Scotland. So we have about 30,000 volunteers as it stands. But really over the last year, we've been looking at how do we include young people between the ages of 12 and 18 into the programme. So it's very kind of sort of new within that stage. We've had to kind of sort of look at what materials we have. We've had to look at how we engage with young people. But crucially, we've needed to try and find ways to involve the young people in actually planning this and helping us with the decision-making process. So we've enlisted the groups, well, kind of quite new youth advisory groups through with the University of Edinburgh, one looking at kind of a sleep study and also looking at a loneliness project as well. So I'm going to take you forward here. Hopefully this is moving. Okay, so these are two big studies. So some of them will be taking place next year, but we've been working with the youth advisory group to help shape these studies. And the young people have been really crucial and instrumental in kind of driving that change forward. So the loneliness study is we're working with 10 young people between the ages of 12 and 15. We've actually been able to keep, we've lost one young person due to family commitments and family circumstances, but we've kept all other young people engaged throughout the whole process. And I think relationships have really been key to that, and understanding what young people are. And what I'm going to do is take you through some of the different principles that we have kind of, tried to incorporate through our process, and thinking about it through a kind of, sort of youth work hat as well, like what kind of sort of makes young people come back and kind of really engage with the programmes we're delivering. They're developing an EMA map, EMA app, so an ecological momentary assessment app, so which will measure kind of sort of their emotions and their sort of levels of loneliness, depending on if they've had social interactions or in-person interactions. And we'll be working with 200 young people next year to try and kind of sort of to just sort of tease that out. But we do want to make sure that we've got young people from across the whole of Scotland, and that we're representing a wide demographic. As well, and look at different kinds of inclusion and equality stuff as well. The other project that we're looking at is an ambient sleep study, and that is a feasibility study, as Heather mentioned earlier, with a new sleep device which will measure sleep patterns over time. So again, that will be kind of getting rolled out next year. So young people have been helping us to shape this. But what we are finding is that the young people that we've been working with have been noticing a lot of things that we have been doing, that it's still a learning journey for us as well, in terms of how young people aged 12 to 15 are engaging with Generation Scotland. And so at the start, young people had to sign up via email addresses, and what young people were saying was, actually, we don't have emails so much, we're using modern technology, but like mobile phones and things as well. What our kind of websites look like, we're absolutely, they're fantastic, but Alex is in the room just now, has been like sort of developing it and making it more kind of sort of young person friendly, and also that it's kind of nicer and clearer for others as well. We have looked at kind of sort of how do we reach out to young people, so we've been going to more events, we've been trying to work with groups as well that are maybe like sort of partner organisations and kind of reaching out to them. We've been doing things with the Rural Mental Health Forum and attending even things like the Royal Highland Show and things. So trying to actually reach out, and we hope to be at Comic-Con in the future as well, but we'll hold that for another time, looking at kind of what size is a Klingon brain and stuff. We'll just watch this space. But young people also told us that there was a huge barrier. So if they were 12 to 15, their parent or guardian had to sign up first. What we were saying was, in terms of accessing even their own kind of health records, they can do that from the age of 12. So we worked with different kind of sort of children's rights organisations and young people to really change that and work with ethics. And I think it was one of the fastest ethics approvals that we have had as an organisation as well, because they agreed and said actually that, you know, we need to look at this and we need to find other ways to include young people. So now young people can independently start that process themselves moving forward. And it's really kind of quite unique for a longitudinal online study to take that approach. And we're, you know, as I say, we are open to keeping kind of sort of moving forward through it. So I just wanted to share this, but just to show an example of some of the things that young people have shaped. So Joni, who works with us as well, you've been doing a fantastic job in doing the measuring of the app, but because of kind of sort of just really the systems that we had and the app, you know, the technology that we had, it was really quite bland before, you know, and young people are saying, actually, you know, would you want to keep looking at this every day? And so they've helped us with generate kind of sort of AI images. We're talking about that obviously this morning, but the power of kind of sort of maybe the positive use of AI. We've been looking at kind of doing different facts and stuff as well included. And also progress bars and things young people were saying was crucial, so they know how long they need to spend on something. I know that everybody in the room will be coming from different places, and, you know, whether you're PPI, PPIE, youth engagement, community engagement, I don't want to be standing here, you know, and telling you this is the be all and end all and this is the way you should do it, because you will all have your own approaches to working with people that will work for the groups that you work with. And young people are no exceptions. They're not a homogenous group. Every young person is different, which is where the relationships are key and where we need to make sure at the very, very start we understand what young people's needs are and we build that into whatever kind of level of support that we are doing. But I do like to start and think about my own practice in terms of the ladder of participation. So, for instance, you know, we've got at the bottom rung here, we've got the tokenism, we've got manipulation and things as well. Nobody really wants to be too much near the bottom of the ladder. Sometimes needs must, and it's maybe a survey or it's something that's kind of sort of short time scale. And we appreciate that that does happen from time to time. But really, for it to be meaningful, you know, youth engagement, we want to be towards these two top tiers. You know, your kind of sort of young people leading the change, young people involved in decision makings, for it to be more kind of sort of powerful and lead to kind of to change moving forward. There are lots of different versions of ladder of participations as well. So if you can have a wee look, you'll see different ones that fit for yourself, and also kind of different levels of co-production and things too. It's quite good to have a look at. So in terms of the principles we use, so this top one here, what I always say is relationships and kind of partner organisations are key. So think about it as like almost that scoping exercise when you're about to set up a youth advisory group or a community group or a PPI group. Who else is round about you? Are there organisations that are supporting people that could help as well to bridge those kind of relationships, but also that they can support them throughout and at the end of your programme too? You know, so if your kind of intervention or what you're working with is kind of short scale, you want to make sure that there's something meaningful at the end of it for your participants and for your young people to move forward. They can also help you if it's something that's triggering. It might be a topic that's quite kind of sort of emotive or triggering as well. So they can still be there and at hand and have those existing relationships to support the young people. We've worked with like LGBT Youth Scotland. We've included the I Will programme, Glasgow Disability Alliance, and many more, Young Scot, Youth Link, etc. To make sure that they kind of help with that kind of linkages and help us with equalities as well. Be authentic and also be clear as well. So if there's things that, you know, young people can't help you with your co-production, just say that, you know, just be upfront, because young people will see through you if not, you know. So if there's things, whether it's due to kind of health or funding related, if there's things they can't do, just, you know, say it right at the start, and they will appreciate that more. They will appreciate that honesty more. Keeping things clear, avoiding jargon, think about kind of sort of, you know, thank you. Oh, I'm not even nearly there. Oh no. I'm going to get beanbags bounced off my head in a minute. So yeah, be clear, avoid jargon. Also, you know, just making sure as well that in terms of that communication that you're not being patronising to people too. You know, it's kind of human nature that you treat people on the same level. Understand their motivations. Why did they get involved? It could just be friendship. You know, it could be that they want to give something back to the community. It could be that they want to do like sort of the work in this arena. Again, find that out because you will keep them engaged and motivated throughout, which then kind of leads you on to the incentives. I know we were discussing it earlier, you know, about kind of whether payment or vouchers. But think about other things that young people are involved in and ask them what they want. So try and make sure that you've got the funding costed in, or you've even involved young people in the funding process at the start. It's good practice. But it could be they want a certification, you know, a certificate. It's maybe job opportunities, opening doors for them, again, making the friendship. We have done something called the Participative Democracy Certificate. I say if you can say it, you can do it. But it's an SCQF level 5 for young people in decision making. We've done Young Scot Awards, Young Scot Points, Saltire Awards and things as well. Again, communication, just keep it clear. Social media, engage with young people kind of on their level. But remember, it's a two-way learning process. We're learning from young people as much as they're learning from us. Relationships are key. Make sure young people aren't burning out, you know, so some of them will be involved in absolutely everything under the sun, you know, and just make sure that you're protecting those young people too. Keep it fun, inclusive practice, remove barriers where barriers may exist, not just for the young people, but also for their parents as well. Provide feedback throughout. I'm going as fast as I can because I really don't want battered with beanbags. Feedback throughout, not just at the end of the process. Young people are the experts and we need them more than they need us often. Evaluate, not at the end of the journey, but throughout, because otherwise you'd lose young people. And make sure as well that you are prepared to change. Don't take it personally if there's something that they're not liking. Just, you know, I mean, take that on the chin, do you know what I mean? And just kind of sort of almost like rise above and change it, because you will lose them otherwise. And then, as I say, just celebrating those successes. So make sure that, you know, young people are, they're included. We've got an event on Friday, and young people will be presenting at that event as well, looking at children's rights, because it was so much more important that they were there talking about that than just us. We do have a video with one of our young people about creating platforms and things on why they got involved. I don't know if we've got time or not got time, right? Okay, but we can share the slides with you, afterwards, or maybe even watch it over lunch if needed. And lastly, just to say, there's no such thing as a wrong or a stupid question, because that's the only way we can learn and move forward as well. And young people, they're not hard to reach. We just need to be more creative about how we reach them. And as I say, working together through that process. And that is me. No beanbags. Wow. Thank you.
Thank you so much, Michelle. We've got time for one or two very quick questions.
Thanks very much. That's me. Just as an aside, I did work in the original Generation Scotland as a nurse, so that's quite interesting. I do look after PPI and it's adults and it's in cancer research, designing protocols and studies, things like that. Really struggling to reach underrepresented groups. Did you find that with the younger people, or are you getting a much broader spectrum than I'm actually managing?
We've been really lucky with the youth advisory groups, and I think it's due to partnerships and it is due to sort of relationships and reaching out as well. If we continually just work with people within kind of sort of the university settings, we can't actually reach more communities, you know, so we do need to work with people that are out there. So we've been really, really fortunate. We've got young people from their experience in poverty. We've got young people from different ethnicities. We have kind of young people with lived experience of mental health as well that are part of our advisory groups. So and always happy to have that conversation as well, you know, if there's things that we can support with.
Time for one more question.
Building on what you were saying in regards to really sort of marginalised communities, do you have any sense, or are there particular approaches you're using in order to draw in young people with learning disabilities or those from neurodivergent?
We've been working with Salveson Mindroom, who are linked to University of Edinburgh as well, to make sure that any of the materials that we're doing, so they'll be part of the testing process. Some of the young people and the groups that we reached out to, like Glasgow Disability Alliance, for instance, have said that the young people didn't feel comfortable being part of the youth advisory group. What we said is that's not where it should end. Do you know, it should be then, if we're using it like for testing it out, for instance, we want to go back to those groups as well, do you know, and very much include them in that process too. So I mean, I think it's always really hard to meet everybody's needs, you know, I really do, you know, like you think about everything, but yeah, as much as we can, we try and remove those barriers. So.
It's just very, like, frankly, what you're describing with regard to good practice around engaging young people. That just seems to constitute good practice for anybody.
Yeah.
What you're saying makes a hell of a sense and a hell of a
Thank you. I don't often get told that, but thank you.
Thank you.
Thank you.
Next, I'd like to introduce Niall Mc Goldrick. He's a clinical lecturer and honorary consultant to dental and public health at the School of Dentistry at the University of Dundee and NHS Tayside.
Thanks very much, Sarah. So clicky button works, that's great. Yes, so my name's Niall Mc Goldrick and I am here to present to you what we're trying to do in Dundee Dental Hospital and Research School. And the title of my presentation is Sustainable PPI, Empowering the Public in Dental Research, Service and Education. And my colleague, Heather Cassie, is also here in the room, and this is a joint piece of work and I'm the spokesperson today. So, declaration of interest, just to start off, I currently have no commercial interest to declare, haven't cracked that triple helix just yet. So, but this project was funded by the Oral and Dental Group within NHS Research Scotland. So we had a small pot of funding to help with some of our outreach work, which has really helped us mobilise around this. Our aim was to convene an oral and dental patient and public involvement group with a focus on underrepresented patient groups. And it's interesting that we've started that discussion here already. I've learned loads from the first two presentations, and if I was to go back and change and do my slides again, I would have loads that I could add in to this. So I'm really finding this session really excellent. So I mentioned the Dundee Dental Hospital and Research School, and this is a tripartite project with NHS Education for Scotland, the University of Dundee and NHS Tayside, three organisations that have worked in the same building for many years in Dundee Dental Hospital and School. But this project aims to bring them together in a focused area of embedding research or quality improvement in every activity, patient contact and process that is undertaken within our building and beyond to ensure effective, sustainable and inclusive care. And our patient and public involvement work is to drive forward that inclusive care element. So what were our methods? This is our lovely building up in Dundee. If anyone's ever had the opportunity or not had the opportunity to see it, you now know what it looks like. And we started off asking our colleagues what current PPI is happening within the building and within the teams that are housed there. And over the years, my colleague, Professor Jan Clarkson, has hosted a range of randomised controlled trials which have had patient public involvement within those in steering groups and committees. But what we found was that PPI beyond these trials was limited and very ad hoc, with no function available for informing our education, so our training of dental teams of the future. And there was a limited function for NHS service within NHS Tayside, with some of the issues around payment that I mentioned in one of my questions for one of the previous speakers. So after this initial scoping work, we brought together a short life working group and we divided our efforts into these three areas of governance, training and recruitment. And we're going to look at each of these in turn. So in terms of governance, about getting our PPI off the ground, starting from nothing, we wanted to understand how we would manage people's data. We were asking questions, how do we share PPI related data across these organisations? We know about, we've heard about IG this morning and all the issues with that. What regulations do we need to consider, and do we need ethics for any of this? So we were very fresh to what was happening. So we worked all of that through, and what we found is that if we carried out an initial data risk assessment, that guided what we could do within the regulations without being too cumbersome and bureaucratic about what we were doing. So we restricted the data that we were going to collect. We would only collect a person's name, their preferred contact mode, and the area of research interest that they had expressed. And this meant that we had no requirement then for a further data protection impact assessment because of the ways that we were holding and managing the data. It was controlled by a central point by one organisation, the University of Dundee, and there was no ethical approval required for this process at that time. So that allowed us to get off the ground, put in our systems to start getting people into our involvement group. But we also knew that we needed some training in our teams, and we looked at what existing resources were out there. And we've had some discussion already about the NIHR PPI guidance notes, and that has underpinned our approach to what we've been doing over the past kind of 12 months or so. We've collated a range of existing resources, Cancer Research UK's PPI resources, NIHR's, and our internal University of Dundee Knowledge Exchange a toolkit. And what we're planning to do is have this in a stored space for our staff across the organisations to be able to access that, and that's going to be on a SharePoint space, which actually does work across the 3 organisations, and you can access it. So that's taken us a while to figure out how we do that also. So once we got through all of the governance, we got on to perhaps what some people might describe as the fun part of this project, and this was around recruitment, and we had to start with public engagement and our outreach activity, and that's where we would drive recruitment into the involvement group. So we started with a meeting and tour of our facilities in the school, getting people to see what our research labs look like, what the educational areas were, our phantom headroom where we train dentists and dental hygiene therapists before we let them onto the clinics with members of the public. And they also saw where we treat and deliver specialist services within the NHS. They met members of our clinical guidance team, national clinical guidance team, which is delivered by NHS Education for Scotland. And that's just one example of an event, but we had a range of different events. We interacted also with third sector groups, and the Brittle Bone Society is one that we've had really good interactions with, and I'm going to explore them as a case study of what we did next. So here you can see some of members of the public within our labs hearing about what we get up to and speaking to our lab staff. We also then went out to the Overgate Shopping Centre, which is in the centre of Dundee, and that was, I suppose, we heard about the Coronation Street effect earlier on. Well, this was the Overgate Shopping Centre effect, and this really boosted our engagement and our involvement. So we're hoping to do more of that. And what was key as we were going along, as we were learning on this journey, we were doing PPI on our PPI. So we were bringing people around and we were saying, do you like this? Are we contacting you in the right way? How often would you like to hear from us? And one of the first things that we did, we thought what we would call our group was Dundee Dental Voices. But very quickly people told us that sounds like a choir for dentists. So we ditched that name and just kept it what it is. It's patient and public involvement for oral and dental research, and that seemed to be much better received. So what has this allowed us to achieve? And you can see some examples of engagement that we've had over the last little while. A webinar series, we've been in Scottish Parliament with the Brittle Bone Society. But what did they tell us about it? Well, they confirmed that our approach to PPI is appropriate, and that is because we had shaped it throughout, so we were quite content to move forward with that. Public engagement really enables PPI, and I think they really complement each other and can't go without the other. And there's a real enthusiasm for involvement around oral and dental services, research and education, particularly around service design. People express to us a lot of discontent with how services are provided. We all know that there are issues with access to dentistry at the moment, but also they're really keen to get involved in research design. In terms of recruitment, what have we managed? I mentioned at the start we wanted to involve underrepresented groups, and over the past, we started our recruitment earlier this year. We've now got 57 people who've registered an interest in what we're doing, and you can see here it's a little bit blurry. I've taken this from our MS forms, but we've got people who've expressed an interest in homelessness, people who've expressed an interest in street drugs, dental services in Dundee, head and neck cancer, and these are some of the target groups that we wanted to start off on this journey. Since then, we've been thinking how we can do more about that. And if there are people in the room who represent organisations or individuals who feel that they're interested, this is a QR code that takes you to the form to express your interest and hear about what we're getting up to. Or if you want to speak to me after, very happy to do that. So what has been the immediate impact of this piece of work? I mentioned we wanted to embed this across our education, NHS, and our research, and you can see here the Brittle Bone Society as a case study of that. In our education arm, we have been able to integrate, we've brought people with lived experience of osteogenesis imperfecta to meet and have discussions with our postgraduate students to inform their understanding of the disease, but also to shape some of the research questions that they may answer in their dissertations, so that we're answering research priorities with the educational activity that we're doing. Our dental school webinar series was an opportunity and a shared opportunity that Dr. Cassie hosted with members from the Brittle Bone Society speaking at that and designing the content of it. They've also been involved in our undergraduate outreach projects, whereby our fourth year dental students go now to Brittle Bone Society, and they will do that on a year-on-year basis and develop prototype interventions to improve oral health for that particular population. They've also been involved in national guidance review and informed that process within NHS Education for Scotland, been involved in developing research priorities, and has informed a grant application submitted to take forward some of these research priorities that we identified. Further to this, the group outside of the Brittle Bone Society, but this broader group, are now supporting 3 PhD studies. They're also in this most recent time, so yes, almost done, supported further national guidance, and this was on periodontal disease or gum disease, and this is just an example of how that has impacted. My colleagues from the Scottish Dental Clinical Effectiveness Programme have just shared this with me. And some really practical things that are coming back. Who's the leaflet actually for? And some of the things about the images that are there as well, which are really helpful. And this has impacted change in that national guidance workflow. What do our staff think about it? Well, they want to do more PPI, so we're hoping what we have developed is a function that now helps them to deliver that. We've got a number of studies who are preparing to get involved in this, and we're having conversations about payments and which standards we should be holding them to. They're really keen to access training, and they generally welcome the approach. And one of our colleagues in the lab, who doesn't often get to see people outside of the lab, said it was great to know that people are interested in what we do here. So it's kind of like a dual benefit from that work. Our next steps are to expand recruitment, to do some more targeted work with underrepresented groups, and we are going to do that with some of our further public engagement exercises that are ongoing. We're almost ready to launch our process for children and carers, and some of you just discussed this really helpful and thinking about how we can support that further, so I'll be speaking to you again. And we really want to make sure that we're evaluating our approach. And when we were talking with colleagues in other parts of NHS Scotland, one of the research questions that they wanted us to think about was, how do we effectively involve people in oral and dental research? So we want to design studies to evaluate and process evaluate what we're getting up to. So that's an oversight or overview of what we're doing. So thank you very much for your time.
Thank you so much, Niall. Got time for a couple of questions. Does anybody have anything they would like to ask?
I guess it's more a comment than a question, actually, because I think we tend to think of patient public involvement and public engagement as separate. And also when we do work with patients, that research and service delivery are also separate. But I think it's really interesting that you kind of brought all of them together, because that's what the community wanted or encouraged you to do. And I'm just sort of advocating, I think we have to have more of these flexible approaches where we're not just doing PPI, where we're doing public engagement to do PPI, and where we're actually allowing patients and service users to direct the things that they want to be involved in. So they may want to be involved in research, but they also want to be involved in service delivery, and I think they have to be more open to those flexible approaches. So more a comment than a
Thank you. Thank you.
Just a quick one. My name's Laura. I work for NES, and I work on ANI programs. So you said right at the beginning you brought those 3 organisations together, maybe for the first time. Well, you brought them together.
Yes, under this project, yeah, they have worked together before, yeah.
Have you had any feedback from your colleagues as to how that's going and how you're getting on?
Yeah, so the project launched last October, the Dundee Dental Hospital and Research School project, and we're at this stage of culture change around that as well, and this kind of how these organisations do work. So this is one of the first projects around this, and understanding how we share data across the organisations is one of those elements. I kind of maybe alluded to some of the issues we're having around payments for PPI, and that differs across the organisations. So trying to get a kind of a joint decision on that and a shared way forward is something we're still working on. But this collaboration builds on the foundations of these organisations working in the same space. So we have got good foundation to work towards, and we're trying to make that smoother. And I think some of the stuff that we heard this morning in the main auditorium, I'm going to take that back and think about how do we make our information governance less bureaucratic so that we can work together. So I don't know if that gives you a bit of an insight in that we are trying to, some of the questions that we've been trying to answer for quite a time, we're now doing that under this umbrella project. Yeah.
Just time for one more question.
I'm Colin Brown. I'm also from NHS Education for Scotland. I'm here officially today in that capacity. I also happen to be a member of Carol's patient public involvement group at the clinical research facility at the West of Edinburgh. So Carol is my handler. And boy, do we get a handle. There's just a couple of points to play back to you and see whether they resonate. I think in my own, and I'm talking from a PPI perspective here, not from an S perspective. I think my own capacity, my own involvement in the PPI group, I'm patient and public involvement all seems to be used as a single construct. And I know that sometimes I'm there as a patient because there will be material or propositions for research or guidance that researchers are looking for, which will be relevant to the conditions that I've got. But in the public sense, I'm there more as a kind of generalist now. Yes, white, male, middle class, professional bureaucrat, not necessarily representative of the population. Quite representative was better than Edinburgh. I live in Edinburgh, put that as one side. Which is handy for the Western End. But I think there's a difference between patient involvement and public involvement, which will be provided by the same person if you can keep the separation. I think there's a third dimension, after my colleague next to me, which is, and I don't want to pick the wrong phrase, but I think there's also stakeholder involvement where you've got professionalised organisations that are there in a representative capacity. And I, in my own mind, I consider that to be slightly different from the PPI group I'm a member of. The final point I'll make is the payment work that's coming up. I just don't. Carol and I have had this discussion. It's quite difficult to say no. Don't try and pay me. Don't try and pay me vouch, because that just complicates my professional life. What's really important to me is time, and it so happens that my employer, once again, is my employer, gives me volunteering. So I use my volunteering to do my PPI work. Now, it might be that as well as thinking about how do you get a consistent approach to payment, whatever that might look like, there's also a consistent approach to asking people what do they want. But you might also want to think about how do you engage with employers to encourage employers to give people a better. If we're employed, I appreciate that not everyone's employed, but where they are employed, how do you encourage employers to perhaps think about giving people some volunteering leave that could be used for this purpose? And for those of us who do work, having that means I can attend the daytime meetings I wouldn't otherwise be able to attend. So some dimensions to think about and perhaps reflect on, and if there are any comments, happy to take them here or later on in the discussion.
Do you want me time to respond? Yeah. So I suppose the second question around the payment, and we do recognise that yes, not everybody wants paid, and your colleague beside you has highlighted that for other reasons. And the process that we've taken is it's an opt-in. We say there's an option to have remuneration for this. Let us know if you want that, and we do make people aware of the impact on DWP and what their interests might be. So there are organisations that have kind of generic text that you can share with people and give leaflets out and say that this may impact on your benefits, be aware of that. So we're working those things through. So I think all of the comments that you've made are really important for us to take away and think about how we make sure that that process is correct. And the first question then around those different hats that you wear, and we all do that in our lives. We're one person when we're home, and then in work we're all different as well. But I think I take from what you were saying in your presentation that there are different ways to patient public involvement, and there are different words that get used as well. There's co-design and co-production, and stakeholders people may use stakeholders to identify organisations or policymakers, or it may well be used to mean individuals as well. So I think it's perhaps the language we get a little bit caught up in, but it's making sure that the process is as inclusive as possible, and that relevant and important voices are included as you go along. So I don't know if that gives a little bit of back to you.
Tiny little comment.
Yeah.
Just going to say, if you're not already a member, you might want to join Generation Scotland. We won't pay you. We might give you rubber chickens, but we won't pay you.
There you go.
Thank you so much, Sharon. Our last presentation is from Amy Ferry, and Amy's a senior researcher at the University of Edinburgh.
So yeah, I'm Amy, a research nurse within the Centre of Cardiovascular Science at the University of Edinburgh. So I work in a data-driven research group, and the team have developed 2 machine learning algorithms to try and help solve 2 common healthcare problems. So the first problem is the diagnosis of myocardial infarction. So chest pain is the most common reason for presentation to the emergency department. It accounts for 5% of all hospital attendances at the front door. But only about 1 in 10 patients are actually having a myocardial infarction. The other patients we have to admit for observation to make sure we're not missing anything. And that is a huge cost burden to the health service. The second problem is to do with breathlessness, acute heart failure. Again, breathlessness is a very, very common reason for presentation. But to diagnose acute heart failure can be quite challenging. The symptoms mimic many other illnesses. But we know that delays in treatment are at a huge burden to patients with very poor outcomes if we don't rapidly diagnose. So the solution to this was to develop 2 independent machine learning algorithms to try and help doctors with that diagnosis. So my colleagues have developed Code ACS and Code HF, each hoping to aid the diagnosis of these 2 very common problems. So machine learning sits within the field of artificial intelligence. It's to do with algorithms which make predictions about events. So in this case, it's predicting whether that patient is likely to be having a heart attack. And then there's a subset of machine learning within it called deep learning. It's much more complicated. It has layers of maths, artificial neural networks. We call them neural because they're like the connections in the brain within a computer. And when I was looking for examples of how to explain this, the one that kept coming up all the time was, if you want a computer to learn to recognize an image of a cat, you have to show it thousands and thousands of images of cats, and it slowly learns to recognize whiskers and fur and the tail and the ears, and those layers of learning eventually form the full image of a cat. So my colleague, Professor Michelle Williams from the Centre of Cardiovascular Science as well, she does a lot of work on machine learning and the image analysis of CT scans, and I've borrowed this next slide from her. So she often shows this slide when she presents. It's a CT scan of a chest, but when Michelle puts this image into a logo, an algorithm to detect logos, it manages to find the Tottenham Hotspur football logo in it. So, you know, it depends what question you're asking the algorithm as to the answer that you get. But for our purpose, we were looking for the prediction of myocardial infarction and acute heart failure. So I'll tell you a little bit about how we went about our PPI plan for these projects. There were 2 independent projects, both independently funded. So at the pre-funding stage, I have a PPI group who I draw on heavily to help us with all our grant applications. So we normally start off with just talking about the relevance of the application to their life and the wider public. And I was working with one gentleman in particular on the development of the plain English summary for the grant application. And it became very, very clear to me that his idea of artificial intelligence was vastly different to what we were indeed suggesting. Now, I don't mean to poke fun at this gentleman at all, but he was asking me, a patient's going to have like a barcode scanner on their neck that you will be able to zap to find out if they're having a heart attack. You know, we couldn't be more different than what we were suggesting. And that made me think we need to formally have a PPI component of this grant as well. So with the group, we developed a PPI plan, and once we had submitted the funding application, we were invited to interview, and I reached out to Carol at that point to see if she had any members of her group who might be willing to act as a lay member on our mock interview panel to grill us before we went for the main grants. She did a brilliant job, actually. The questions that she asked us during the mock interview were most closely aligned with what actually happened on the day than anyone else on the mock interview panel. And she actually decided to stay part of our group as well. I haven't totally stolen her from Carol, but she works very closely with our group now, so I'm delighted that she wanted to stay part of the project. So as part of the funded work, we decided we needed to do some focus groups to find out really more about patient and public attitude to artificial intelligence in healthcare, what patients need to know about AI-facilitated assessment, and how we should frame it for public acceptance going forward. So my participants for the group, they were my existing PPI group. Now, most of these people have experience of chest pain. That tends to be where our work has focused in the past. But I was very aware no one in our group at all had experience or acute lived experience of heart failure. So I liaised with our heart failure specialist nurses at the Royal Infirmary, and they advertised in their clinic for people to come forward to become involved in the group. So I got some new members that way. And then there were some people as well who didn't have lived experience of a healthcare condition, but they have a general interest in healthcare research. So the groups I ran, I tried to be as open as possible to all different modalities that people want to take part in discussions. So I held face-to-face discussions in an afternoon. I held online discussions in an evening for people who maybe at work and couldn't attend other ones. I do have some people who are quite uncomfortable speaking in a group setting. They wanted to do one-on-one. So I had one face-to-face one and one telephone conversation. And so 12 participants in total informed this work. So the learning that we gained from this interaction, I'll just say I've also stolen this phrase from Carol as well. You know, we talk about impact in PPI a lot, and I find it quite difficult to demonstrate impact sometimes, but we can always demonstrate the learning that we've had from these interactions. So the first thing, I did give people like a topic guide, I guess, of subjects that I would like to discuss, but I was also very open to them bringing things to the table as well. So we talked about the general concept of artificial intelligence, and people were generally familiar with it, more so in applications outside healthcare. People were talking about braking systems of cars. Somebody mentioned how their washing machine was able to adjust the amount of water that it used depending on the load that was in. But nobody was aware of any personal experience of the use of artificial intelligence in healthcare. And we certainly heard this morning, it's out there, it's been used, but nobody really knew that that was happening. But everyone was generally supportive. They viewed it as a natural progression. It's where we were heading. And then there was something about acceptability. it was generally positive. The first question that I asked people were what words came to mind when we started to talk about artificial intelligence. It was fear, data, robot, this kind of image of robot doctor was very strong in people's minds, and the gentleman who thought we were going to have a barcode scanner to work out what was wrong with people. But then when we started drilling down into what we meant by artificial intelligence, the terminology of machine learning was much more applicable to what we were doing. It is what we're doing, it's machine learning, but it was also much more acceptable for people to talk about a machine learning algorithm than to have this image of a robot doctor. But there was the caveat as well that people were very keen to point out that patients are different, patients are worried, they can be anxious and vulnerable, and space should absolutely remain for human interaction, which is exactly what we're proposing with these algorithms. They're not meant to replace a doctor's assessment at all. They're meant to aid the clinician in making that diagnosis. And I did ask the specific question of, do you need to know that artificial intelligence is involved in your assessment and diagnosis? And every member said no, they didn't need to know that. They were very accepting that whatever healthcare was offered to them was evidence-based, and it was what we should be doing as practitioners. So maybe we don't need to worry about it as much as we thought. And then there was the relationship with humans. So kind of as I've already said, there was a strong preference that these algorithms should support rather than replace the clinical interaction. Now, patients put a lot of emphasis on gut feeling, and that seemed to have an awful lot of power. And it was felt that artificial intelligence couldn't replicate that gut feeling. That was something that you got from years and years of clinical experience. But then when we got to talk more about how the algorithms were developed, the fact that they are based on a cohort of 10,000 patients, then the group decided that it's probably quite unlikely that a single doctor is going to assess 10,000 patients in their career for chest pain. Some clinical colleagues may disagree with that. But yeah, then people did decide that maybe it was akin to clinical experience, the fact that 10,000 patients have been involved in them. Really? Okay. Next was what patients wanted us to be focusing on. So speed and accuracy of diagnosis was a major thing. That's what these algorithms are hopefully going to do. And it was really nice to hear about the equity of healthcare that everyone was talking about this morning. That came out quite strongly in our discussion. So it was nice to see that parallel. Again, disease prevention, we should be focusing on prevention rather than waiting for diseases to happen. If we think of healthcare at its absolute most basic form, it's communicating with patients that's important, and people were wanting us to focus on ways we can improve this, and monitoring of patients possibly to live without the need for lifelong medication. Yeah, people thought that there is the possibility that you could have a more accurate diagnosis. The algorithms can draw on an awful lot more data than any human ever could possibly boost performance of more junior staff, and also you don't get tired, or the algorithm doesn't get tired like the doctor at the end of the shift, and it can maybe again produce that equity of consistent diagnosis between different clinicians. And a few patients thought they had an incorrect diagnosis on their initial assessment, and the AI could have possibly prevented that from happening. Patients did ask very, very pertinent questions about the truth on which the algorithm was based, and yeah, maybe I sold them short, but I was quite interested how interested they were in the science behind the algorithm. They wanted to know the weighting given to the different variables. The algorithm's made up of 10 different variables, and you know, how much weighting was given to the fact that it was a man versus a woman, for example. But yeah, one of the overriding things was, I guess we touched on it earlier as well, people didn't want the algorithms to get in the way of the patient telling their story. You know, patients really value that interaction. And again, as we were hearing about earlier, that potential for collaborating with industry, people were worried that there could possibly be a data breach if that were to go ahead. So just to finish then, our summary, yeah, I think the project did highlight the need to explore PPI. to explore patient understanding of AI in healthcare, and it has possibly raised the scope to do a more formal piece of research in this area. We gained insights into how patients will feel during assessment. We've learned about terminology, which is going to be useful when we go forward to trial these algorithms in a clinical study context, and have learned about new research ideas that patients would like to take forward. Thank you.
Thank you so much. To keep people from their lunch, but if we did have maybe just one question.
Thank you for an interesting talk. In the funded PPI work, did you employ formal qualitative methods to analyze what the patient involved in?
That's a really good question. So my job by trade is a qualitative researcher. So I didn't do it formally, but I guess in my mind I was looking for the themes of things that were coming out, but I didn't record and formally code all the transcripts for them. Yeah.
Thank you. Now, just before we let everybody go, Carol, do you just want to say what the notes are for?
Yes, thank you. So I know you're late for lunch, and I know everyone is desperate to get to lunch because we've had a long morning. We are doing a patient public involvement event solely dedicated on patient public involvement at the B&A in Dundee on the 12th of March next year. So colleagues in Dundee might be pleased that we're coming to see you. And if you have ideas of people that you want to see speaking there, or topics you want to see at that event, I've put notes, I've put blank pieces of paper on the chairs. Write your ideas down, pass them to me downstairs when we're having lunch, and yeah, I'll hopefully see a lot of you at that event in Dundee in the spring. Brilliant. Thank you, everyone.
Thank you.
Have a good rest of the day.